Adebola Olayinka is currently a consultant with the World Health Organization, working with the Emergency Preparedness and Response Cluster. Prior to this, she had been a research officer for high-threat pathogens and coordinated research on Lassa fever for Nigerian Center for Disease Control, NCDC, working through the World Health Organization. She was senior technical advisor to the DG Centers for Disease Control and Prevention, CDC, and had also worked as resident advisor to the Nigerian Field Epidemiology and Laboratory Training Program. Dr. Olayinka was a professor of medical microbiology at Ahmadu Bello University with a background in medicine from the University of Ilorin, a master's in public health, and a clinical microbiology specialist. She has been principal investigator on several projects. She has provided technical guidance as an expert for epidemic preparedness and response to several countries across the Afro region. So on this note, Professor Adebola Olayinka.
Thank you very much. I'll turn off my video because of the bandwidth, but I believe you can hear me clearly. So we'll be taking a look at the public health response in Nigeria, and we're going to look at the role of history regarding Nigeria. I'm using Nigeria as a case study. Apologies, I'm not sure what happened. I'm going to reshare my slides. Can you see my screen, please?
Yes, we can see. I can see from here.
Okay. Okay, so why are we talking about the history of public health response? You are basically historians, so you know that histories help us to learn about how past systems and governments or cultures were built. It tells us how they operated, how they evolved. And as we understand these past events, it tells us how we got to where we are today, and it provides us with lessons from the past. These lessons help us to avoid previous mistakes and to also create better paths. And there are many lessons we can actually learn from the history of public health response. And I hope that these lessons will help us to shape the future. So looking at public health response, why is there so much focus on public health response? We've had the humanitarian side, and I'll be talking about the public health response side. In recent years, we've had emerging and re-emerging diseases. Emerging diseases can be termed as those diseases that pop out of nowhere, like COVID. And then we also have things that we call re-emerging diseases, something like the monkeypox, or as it's now called, mpox. And what these do is to tell us about the need, why our public health systems need to be strengthened. The most recent COVID pandemic brought that out very clearly to the whole world, because not only were the developing countries struggle, we also saw the advanced countries, the more advanced countries struggling and trying to respond to this pandemic. So when we talk about public health response, we need to look at what we've done in the past, what we did right, what we could have done better, learn from that and strengthen this going forward. Now, if there's a lesson to learn from COVID, that lesson is that infectious disease outbreaks can have a huge impact on not just the health of the people, but the economy, the social structures, life expectancy, and just name it. So like I mentioned, I'm using Nigeria as a case study. For the benefits of those who might not be very familiar with Nigeria, It's the most populous African country with a population of more than 200 million. It's situated in the western part of Africa, has 36 states with a federal capital territory. And across these 36 states, we have sub-national units, which are called local government areas, and there are 774 of them. Now, I'm giving this background so that you understand the enormity of providing public health, of providing health care and even responding to emergencies in a nation such as this. We actually say that Nigeria is many nations within one. So the provision of healthcare in Nigeria is currently the function of the 3 tiers of government: the federal, the state, and the local government. So with that, we have what is called the primary healthcare system. We have the secondary health and the tertiary. Now, additionally, at the federal and state levels in the ministries of health, we have the public health department, which is really responsible for the detection and response to public health events, and each state coordinates with its local government areas. And this is just the map of Nigeria and its location in Africa. So now coming to the history of public health in Nigeria. Public health is really about promoting and protecting the health of the people. And in promoting and protecting the health of the people, the ability to prevent, detect, and control threats like infectious diseases is very important. And the truth is, the concept of public health has existed even before we coined the name or the term public health. If you have a look at African local communities, there are several indigenous and traditional ways that have been used in responding to disease conditions. There have been preventive and curative practices that have been in place in various Nigerian and African communities before the coming of the colonial masters. And some of them are still in existence today, even though some may have been discarded, some have been redefined, and some have been upgraded. We have systems like the traditional birth attendants, we have herbalists, and so on and so forth. But looking at how the health system developed in the country, in the pre-colonial era, there were these organized medical care that were organized by the colonial masters, and they had this primarily by the missionary agencies. And so they had different rural facilities around, and they had like bigger stations on the offshore islands like Cape Verde, Fernando Po, which is current-day Equatorial Guinea. By early 19th century, those missionary agencies had built health facilities and hospitals, which they owned in Nigeria and across other countries in Africa. By 1898, the ruling government then had now established some government facilities, and the military also had its own healthcare facilities, which were in addition to the existing missionary facilities. And these facilities were called the West African Medical Services, or the government or colonial medical services. And they existed like that. In 1920, Dr. Isaac Oluwole, who was the first public health physician that returned from Britain and became the first African medical officer of health in the Lagos colony then, deemed it fit that it was time to train a pool of Nigerians in country. And so he established the Nigerian School of Hygiene in Yaba. And that was where, for the first time, Nigerians were trained and qualified to become sanitary inspectors. Then by 1954, Nigeria was divided into regions. And each region now had its own medical services, which were known as the regional medical services. And these regions remained operational until Nigeria gained its independence in 1960. So before the independence, there was a 10-year development plan that was introduced to enhance healthcare delivery. And with that 10-year development plan, there was the setting up of the Ministry of Health and several other clinics and health centers across the country. And there was also the setup of some schools of health. Following the region-based medical health services, when Nigeria was now divided into states, then we had the state health services, and that led to the development of the ministries of health, which we have till now. But it began to be obvious that the state alone could not cater for the whole country. And so there were subdivisions into the local government areas by the setup of the Basic Health Services Scheme, which later transitioned to the primary healthcare services that we are aware of today. And by the 80s, we had over 10,000 health centers established in the country. And then there were bigger hospitals, which were known as general hospitals, and then university teaching hospitals and tertiary facilities. Now, before I go on, now looking a bit more closely at the public health response, I want us to be aware of the 5 core components that make for an effective public health response. We have emergency coordination, we have surveillance, safe and reliable care, community protection, and access to countermeasures. In view of the time, I cannot tell you the whole history, but I'm going to focus on surveillance. Surveillance is the ability to detect a public health threat. And surveillance consists of the surveillance, the health information part, and also the laboratory diagnosis and testing. So looking at public health delivery in the country, in 1937, the Federal Lab Services was established with its headquarters in Lagos. And that Federal Lab Services now had a bacteriology unit, which was located in Yaba in what was known as the medical compound. That medical compound it was a convergence for several public health facilities. So in that compound, there was the vaccine production unit, there was the Central Medical Library, there was the Federal School of Medical Lab Technology, which is now located in Jos, no longer in Lagos. There was the Drug Manufacturing Laboratory and the Medical Research Council, which is today the present-day Nigerian Institute of Medical Research. You can see that some of those facilities are currently defunct, like the Drug Manufacturing Lab and the Vaccine Production Unit. But in those days, Nigeria was producing vaccines for yellow fever, smallpox, and rabies. And then there have been many pandemics, and I'll give you an example of 2 and use that to link with the history of public health in Nigeria. The very common flu pandemic of the 1918 and 19 started in Europe, and then it spread to the rest of the world, including Africa. The first case in Africa was in August 19, and it was, the first case was from a boat that had departed from Britain and was in and then birthed in Freetown, Sierra Leone. And then there was another American vessel that went from Freetown to Cape Coast and to Accra. And what happened was that because there was a pandemic and there were people who were already infected, who were exposed and infected traveling, the pandemic moved from Europe, from America, came to West Africa. And by September 14 in 1918, the flu had hit Lagos through the seaports. Of course, with that, many people were exposed, people who walked around the boats or on the boats, and they got infected. During that region, travel by train was the major mode of travel in the country. And of course, Lagos was the central point of the country, and it still is. So from Lagos, many people traveled, and before you knew it, there was flu along all the places where the train had stations. Of course, travel continued, and there were other ships which were berthing in other seaports in the country, like Port Harcourt, like Forcados, Calabar, Warri. And so by December 19, the flu pandemic had spread across the whole nation. Now, another example is the Marburg outbreak, which was identified in 1967. This was identified among 31 laboratory workers in Germany and Yugoslavia, with 7 people dying and 31 infected. And it was found out that they had imported this virus from the monkeys which they had transported. The name Marburg is the name of a town in Germany. So in those days, they named viruses based on where they were discovered. Now, another one which is very present in Nigeria is that of Lassa fever. Lassa fever causes yearly epidemics in Nigeria, and it's endemic in many countries across West Africa. So the story is of January 1969, when there was an American nurse who was a missionary nurse in the Lassa village in Borno State. She became ill. Very ill. She was transferred to the Bingham Hospital in Jos, but she died 6 days after onset. And then 8 days later, another nurse who attended to her became ill with a similar illness and died. Now, when the 2 of them died, there was a doctor and a nurse who had attended to them and also performed autopsy. Within a week, both of them fell ill. The doctor died in Jos, but the nurse Penny arrangements were made to fly her back to the US, and they also took the samples with them to the US. And in the US in 1970, the virus was identified, a similar virus across the 3. Penny survived after 9 weeks of very grave illness, and the virus was named Lassa after the village in which it was found. Now, why am I telling us this history? I'm bringing this history because for decades after the flu pandemic, after the Lassa fever virus was detected, for many decades after that, the identification of these viruses were not being done in Africa. Even though there were many travel-associated cases outside West Africa, for any testing, they were still being done outside the continent. Until around 1993, when there was a hospital laboratory in Sierra Leone. Sierra Leone is also another country that is endemic for Lassa fever, and they made attempts, but they had the civil war, and then they could not come back until 2004. Meanwhile, in Nigeria, people had been dying. Sometimes they were thought to be serious malaria, typhoid, or whatever it was, and healthcare workers were also dying. And then in Edo State, around 2001, from 2001 to around 2004, there were classic cases which resembled what had been described about Lassa fever. And then there was this man, Professor Sunday Omilabu. He's still alive today, and he's still at the Lagos University Teaching Hospital. He now made attempts and decided to ask for retrospective samples from the Edo State lab and to find out if it was really Lassa fever, and then it was Lassa fever. And unfortunately, as I speak today, there are still many facilities in the country and across Africa that do not have a capacity to make a diagnosis of Lassa fever today. So by 1989, and I'm coming back to the history just to make the case on why there is a need to strengthen the public health system and learning from history. So if we go back to that federal lab service that was in Yaba, by 1986, the government decided to build a bigger laboratory. By 1989, it was renamed the Central Public Health Lab. It was given a bigger building, and then the lab was given additional responsibilities that in order to just looking at TB alone, it should support the diagnosis of epidemic-prone diseases. So between 1990 and 2000, the Central Public Health Laboratory increased its scope and services. By 2006, it was designated as National Reference Lab for yellow fever, measles, and rubella by the World Health Organization. And by 2015, by the West African Health Organization, it was designated the Regional Reference Lab for cholera and other enteric pathogens. So in 2011, the country established its National Public Health Institute, which was the Nigeria Center for Disease Control and Prevention. But it took an additional 7 years, 2018, for the bill for the act to establish it to be signed into law by the government. Now, over the century, there were many diseases that had continued to plague the country. Lassa fever, meningitis, measles, cholera, yellow fever, polio, monkeypox, and even within that period, Ebola came. One of the key things that happened with the establishment of the NCDC was that it became an important turning point in Nigeria's fight against infectious diseases. So in 2016, the NCDC had a new DG who understood the importance of having a national reference lab, and the change began. I'm happy to say that I was part of that change because 2017, I became the first consultant to be asked to ensure that we had a national reference lab within the country. But we didn't have a molecular diagnosis in the CPHL until 2018. 2017, 2018, we also had it in the NCDC. But the good thing is that in the last 5 years, there has been an opportunity for transformation of this 86-year-old public health institution within the country. And by the time COVID emerged, the diagnostic system in the country was better prepared. So this is just some pictures showing us the previous Central Public Health Lab and the current one. And then to the left, we have NCDC. To the right, we have the National Reference Lab now in Gadowa. The CPHL serves as a campus to the National Reference Lab. Now, in talking about the development of public health diagnosis in Nigeria, decentralization played a very key part, and we cannot underestimate the role of other laboratories that contributed to this. So in 2001, due to the recognition of Lassa fever, endemicity, and high burden in Edo State, the government set up the IRA Specialist Teaching Hospital as a center of excellence in the management of Lassa fever with 2 other federal tertiary health institutions. By 2008, the ISTH had built a diagnostic and research laboratory which started operation in September 2009 and was able to diagnose Lassa fever. We remember in 2014 when we had the first case of Ebola. To be able to make that diagnosis, the sample was first tested in the same lab that showed the first interest in Lassa fever. And then samples we also shared them with the Redeemers University, and they confirmed the Ebola. We remember also when COVID came, by then, we had quite a number of labs that could test for COVID. So where are we now with regards to public health diagnosis within the country? We have an improved capacity for detection of public health threats. Lassa fever, COVID, monkeypox, diphtheria, these are all being tested within the country. We have an improved surveillance, so it's not just guesswork. We're able to confirm in the country. We have a national reference lab with the biobank, and then this provides coordination with other labs across the country. And then there's a sample transportation mechanism where from every capital in the country, samples can be sent to that lab. And the lab is also working on quality assessments with other labs. With time, we've had many states in the country having state public health laboratories. University research laboratories are there, teaching hospital laboratories are there. There are many research institutions across the country who contribute to this surveillance. And then a lot of these labs have been pulled into different networks for various diseases. So what are the lessons to learn from history? You remember at the beginning I said, we look at history so that we can learn lessons from them. One of the key things that every country, Nigeria and every other developing country, needs to learn from history is that it's important to have a strategic plan for development. What are the goals? What are the objectives? But beyond having the plan, it's important to monitor that plan and evaluate and make sure that it's being implemented. The other lesson is that funding is critical. A lot of development did not happen because there was no attendant funding, even when plans were developed. One thing that has helped the country has been the value with partnerships and strategic collaborations. And then the country needs to invest in capacity building, invest in the people, invest in structures, invest in systems, and invest in materials. One other thing that developing countries will need to really focus on is innovation and adaptability for the things that are prevalent within our countries. And then we need to focus more on research. And we need to go beyond basic research and look at applied and transitional research. And last but not the least, technology development, production and industrialization. A typical case is Lassa fever. 54 years since the discovery, there are still no vaccines for this disease. There are no approved or tested medications. There are no rapid diagnostic tests. And you look at the rapidity with which vaccines were developed for COVID, with which vaccines were developed for Ebola. And sometimes you ask yourself, is it because Lassa is a disease that is limited only to West Africa? Is the world waiting until it becomes a pandemic like Ebola before they respond rapidly? So finally, I want to acknowledge the following people that I know personally who have been very key to some of the recent developments we've had in public health in the country. Dr. Adebayo, I spoke with him and he's been a part right from the federal laboratory up till the NCDC lab. He was the first director of the lab. He's retired now. And he gave me a lot of this history. Sunday Omilabo, I've mentioned him. The next three are the various leaders of the NCDC, the staff, and then all these other people who have in one way or the other contributed to the public health history of Nigeria. Thank you, and I stop here.
Oh, thank you so much for that wonderful presentation. You've taken us through the history of public health in Nigeria and the need for humanitarian response and services in Nigeria, and also the impact of COVID-19 and Lassa fever in Nigeria that actually calls for the need for humanitarian response in Nigeria. So thank you so much. We really appreciate you. I think I've learned so many things from that wonderful presentation. And without wasting time, I would like to invite